Our presenter, Jamie with Colorado Access, is going to give a presentation on care management at Colorado Access.
Hi, everyone. Thank you for having me today. My name is Jamie Zayas, for those of you who I have not met yet, and I'm our Senior Director of Care Coordination over at Colorado Access. And this July, I'll have been here 10 years at COA, so it's hard to believe because Mandy, back in the day, you were with us here. So it's been a while, and I've had the privilege to do about every role in our department. So I started on as a care coordinator and have just done all the roles. And even when we were had a single entry point, I supported those teams. So I've been lucky to have a lot of different touch points in my career here at COA, and I'm excited to share today a little bit about our care coordination department, kind of dispel some of the myths that we often see in the community when members come to us about what we can and what we can't do. And I'll try to link some dots as well as to how our team supports connecting members to specialty care, things like that. So I should say care coordination overview.
All good.
Okay, cool.
Woohoo.
Awesome. So just a refresher before we dive into kind of how we're set up, you all recall that the state now has 4 regions across the state for regional accountable entities. Colorado Access, we are now Region 4. We were formerly Region 3 and 5, but after July 1st of 2025, we are now Region 4, and we support Adams, Arapahoe, Denver, and Douglas counties now. We no longer support Elbert, that moved to another Ray. So right now we have about 480,000 members across our region. And so when we think of care coordination, we have 2 types of models here at Colorado Access. So we have, we'll call it the health plan led, which is my team. That's our internal staff at Colorado Access who provide care coordination to our members. And we have a team of, a continuum of staff that we'll get into later with their experience. And then we also have care coordination partners, also known as CCPs. And these are clinics that we partner with that get an additional per member per month payment to provide care coordination services for our members. So I'll share that list of clinics, but we'll get into kind of how many we have, but we have 2 different types of care coordination happening at Colorado Access. So, there's benefits to both, right? On the health plan side, it's really great because my team is really great at navigating the whole spectrum, getting the big picture, navigating some of those nuanced things that at a provider's office you may not run into all the time. And then on the provider side, they have that advantage that they're in the clinic. They have that trust already with the members. And so we have both here at Colorado Access. And when we break that down, when we think about my team, we have 7 internal teams with 62 frontline staff. So they're made up of different types of staff. So care navigators, doing more of the answering the phones on the front lines, really supporting members with those one-off kind of one-time phone calls. And then we have care coordinators, intensive care coordinators, and youth intensive care coordinators. And really what that means is the acuity or type of level that they'll work with. So our care coordinators handle the lower acuity members with ongoing needs. And then our intensive care coordinators and youth intensive handle those highest acuity members. Really what our team does internally is we provide for members who are not connected to a care coordination partner. If members don't have a provider that they're connected to at all, like we make sure we connect, we're available to them for care coordination. And we provide the behavioral health care coordination for all the members who need it. And then we have a special group that came out in July of 2025, the COSOC, another acronym, Colorado Systems of Care, and that's really designed to support youth, aimed at trying to keep youth in the lowest restrictive setting as possible. And so that's where those youth intensive care coordinators come in. Of course, we have other leaders on the team, an auditor, program manager, et cetera. On the care coordination partner side, we have 15 care coordination entities right now across 88 sites. And really, the types of staff vary by site, but they really are going to provide the care coordination for members that are assigned to them or attributed to them. And they support things related to their physical health, social determinants of health, and transitions of care needs. So when we think about our population, like I said, we have 480 plus thousand members, Medicaid members. For those of you who don't know, we also have a Child Health Plan Plus MCO. So we support about 50 plus counties across Colorado for CHIP. But we're going to talk today mostly on the Medicaid side here. When we think about our membership, we think about a funnel, if you will, and we have three tiers of members. And so we have all, when we think about it, all members, regardless of their acuity, are going to receive different types of messaging for us, potentially text programs, things like that related to prevention, wellness, education, things like that, really through more digital platforms. And then we have this like middle layer of members, more of the, we'll call them tier two members that really have, more chronic conditions. Those members may receive a combination of digital interventions as well as care coordination from either the health plan or the care coordination partners. And then we have our tier three members. Those are our highest acuity members that get involved more with our team specifically. And all of our members, all of the Medicaid members are eligible for care coordination, but that does not mean that every single member has a care coordinator. So unlike a case management agency where everyone is assigned to a case manager, we are more event or needs based. So not everyone is assigned. I mean, you see the math, 62 staff members for 482,000 members. It's we can't have everyone assigned, even with all of our help from our clinics. So when we think about how do these members even get identified, we get asked this a lot, like how does somebody even fall into care coordination? How do they get, connected? And there's a lot of different ways that a member may become identified. So we get notifications from our utilization management department related to admissions. We have clinical registries to support our pregnant and postpartum members. We get daily admit, discharge, and transfer data for our members who admit to the hospitals and emergency departments. Again, we stratify and we outreach members with the highest acuity or the highest tier for care coordination interventions. And then we have several complex subpopulations, we'll call them, that you can see here that we do some programming for. Members also come into us through different community partners, providers, healthcare policy and finance. Members may self-referral, families refer, and often. And they can all do this by calling our care coordination phone line that is listed there. And we also have a digital referral form. So again, I'll send this deck to Mandy so everyone has that link. But that is how somebody would be identified to get a care coordinator. So we think I often get asked this too. Well, how long do you work with members, Jamie? How long does your team, how long does it take to respond? And really, it depends on the member's needs and what's going on with the member, their goals, the exact situation. So for some members initially, we might be outreaching every day or a couple times a day, depending on the situation. For other members, it might be a quick touch base once a month because maybe they're working on something and they just need us to check in periodically. So it really does depend on the member's needs. When we think about on the provider side, it may be more every time they come into the office, right? And we know they're not coming to the office weekly most of the time. And I like to highlight that while we would love to solve all members' issues on the same day, that doesn't always happen, right? Sometimes the coordination requires several conversations between providers, other agencies, and community partners to really help resolve a member's challenges. And so while we strive to do as much as we can, it can often take several phone calls, meetings, things like that to resolve the issues that come to us. Typically, if you were to make a referral or a member self-refers, we will get somebody assigned to them within 2 business days to outreach. Of course, if there are more urgent situations, we can look at those on a case-by-case basis. So what does a care coordinator do exactly? When a member comes into us, the first thing we are going to do, whether you are on the provider side or the plan side, is we're always going to assess the member's needs. And based on those needs, it will help us create a care plan with specific goals that the member really wants to focus on. Oftentimes you do an assessment with a member and there might be 20 things that come up during that assessment that a member has a need for. So we really do work with members and their families to prioritize what are the top 3 to 5 things that you want to focus on now and chip away at that list if it's a big one. We aim to connect the members to different resources and additional support in the community. So oftentimes that is specialty care. We realize after assessing a member's needs that they do need a specialist. And so our team will help support members in the search to find specialists that are accepting Medicaid. A challenge we often run into when it comes to specialty care is the time to get in. So tips that our staff, you know, encourage members when we call is one, talk to members about being open to see either the physician assistant or nurse practitioner at an office. Don't get your heart set on that one doctor. If the practice has several doctors or other PAs or nurse practitioners, be open to seeing them. We also encourage our members when connecting to specialty care, you know, ask about getting on the cancellation list and, if something were to come up earlier. So I wanted to make sure I connect that dot that we are often working to connect members to those specialists. We also work closely with the members of the care team, with providers, with case management agencies, with the school districts, with advocates. We want to make sure that everyone knows what they're all doing for the member, who's responsible for what action item. And so that often involves a lot of interdisciplinary team calls. If it gets escalated, we can invite the state to those for more creative solutions or complex solutions type calls. But that's what we're doing for members. We're really trying to help connect them, break down those barriers, and work collaboratively across the care team. When we think about what excellent care coordination does, I like this analogy of a symphony. If you've been to an orchestra, you've got the conductor. I think of that as like the ray that we're kind of conducting the orchestra, and that if you've ever been to maybe a middle school concert where maybe they're not quite there yet, like that they're not at the Colorado Symphony Orchestra level, you can see it's like, oh wait, when do I come in and start my piece? Really, we hope it flows more like a Colorado Symphony Orchestra concert when we think about what does high quality care coordination look like. So it looks like, we are closing the loops, that if we make a referral, we're ensuring that that organization or entity we referred to, the member followed through on, right? We want to make sure we have strong team communication, that everyone stays aligned, stays in communication so that that member has a positive experience. And we also want to empower members to educate them to be drivers in their own health as much as we can through education about signs and symptoms, when to use an emergency department, when do I use urgent care versus when do I go to my primary care. Different things like that to really empower them. Does it always go as planned? No. I will say, while we wish it did all the time flow just like this, there are bumps often, and we try quickly to course correct. So how do we support exactly? We help connect members, like I mentioned, to appropriate providers. We coordinate across the care teams. And again, I already shared this about being open to seeing nurse practitioners, PAs, folks like that for faster access. We're able to connect members to different groups in the community that are able to support with benefit applications. We can help members understand certain processes, whether it's about transportation, appeal processes, things like that. We help connect members to community resources related to housing, financial assistance, and help navigate what can be a very complex housing system across the state. We're able to call facilities and providers on behalf of the members to help troubleshoot. And again, I already mentioned we really like to coach members about the cancellation list, things like that, to make the most of their appointments or how to get in faster. We're able to connect members to non-emergency medical transportation, including out-of-state transportation if that is a need for a member, if they have to get treatment out of state. And we work closely with, different entities as well to connect members who need more of that day-to-day support for daily task support. So we often refer to Atlantis Community Other Brain Injury Alliance is another one. Several organizations that we work to connect members to. And of course, we have strong partnerships with our case management agencies because many of our members do have a waiver service. So we do a lot of support with members in those areas as well. And again, really helping to connect and provide that support to help them meet their goals. Some of the things that we can't do that members come in thinking we are able to help with is they think we are like their doctor, that we can prescribe things or we can change a doctor's opinion on a treatment plan. So we are not a provider. We do not diagnose or treat. We can't override any provider's decisions. We are not a nurse advice line and we are not an emergency department. Our team is also not able to complete applications on behalf of members, but like I mentioned on the other slide, we will help get them connected to places that can help them. And something else people always say, oh, well, if I give you my new address, that should feed into the state system or the county system that has all that. We do not have access to do that. So if a member calls us and they want an address updated with the state for their Medicaid, we have to encourage them to either do that through the Peak website or call the county to make that update. We're not able to do that. We do not, while I wish I could build houses for everybody, we do not have any funding for our members for emergency placement or any assistance for rent. So again, we will look for those community partners that do have those kind of things. And we often get questions about, well, you should be able to move a person up a wait list, right? It's 6 months. Can't you have them seen next week? And the truth is we have the same place. We have no special door access to anyone to move somebody up a wait list. Again, we try to use those tactics of the cancellation list and others to try to get somebody up a little quicker, but we can't get anyone in any earlier. Nor can we force any facilities to accept members, right? Each facility, when we try to get members admitted to facilities, has their own criteria, so we're not able to change the trajectory there, but we'll help gather information if the facility needs more information about the member to make a decision. We do not drive members or act as personal assistants. Sometimes people come in hoping we're going to drive them all the places and do all the things for them. We are not those things. And we're more event-based. Again, we do the best we can with the number of staff we have, but we really try to encourage folks to be empowered and give them the tools so that they can support themselves, but we're always here when they need us. And again, all members are eligible for care coordination, but all members don't necessarily have somebody assigned. We've kind of already touched on all of these things here, so I'll kind of get through this quickly because I know I'm close to my hard stop here, but our team strengths, I really love to highlight this. I like to brag on the team. We have a diverse backgrounds of people that come from all over different areas, from hospitals, from clinics, from community sites, all over the place, and they bring a depth and breadth of knowledge to support the most challenging scenarios. And when I think about it, it's like hundreds of years of experience across all these staff. They're really great at helping with those acute situations and helping members attain their goals. They are the most caring bunch of people I think I've ever met. And they really do strive to provide the best customer service they can and follow through. Again, I talked to one of our member groups a few weeks ago that did not have a great experience. And I will highlight that sometimes there are situations where that can happen, and we do our best to quickly address those situations. So I've said a lot. I would love to hear really, what questions you all have. Here's how to get a hold of us. And I'll send this deck to Mandy. These are our care coordination partners, again, that members can be assigned to. So I will share this deck with you all, but I'm going to stop sharing so I can come back on camera and see what questions you all have for me. We are, working closely with healthcare policy and finance. We have an internal team that is working on what that looks like on our side. A big part of it is going to be the education. We're working to try to understand whom of our membership is going to fall off so we can try to proactively outreach them. We're working on, different toolkits that we'll be able to share with community partners. Things like that will be coming down the pipeline. we are also working on getting my team redetermination data so that we'll know when a member is due for redetermination. So as we're interacting with them, we can say, hey, did you know that you're going to be due for, signing back up in, X amount of months? Make sure your address is up to date. Make sure you're looking for that packet, things like that. So we are working closely with the state and we'll probably have more updates. I can connect you with Liz Owens in the future as
Okay.
things get rolling. She's a great
Alrighty.
contact.
Okay.
Do we have an idea of how much care coordination costs per patient? That is something we're trying to figure out right now, actually. I'm working with some actuaries to really get down to what it costs per member. Uh, and we're working through that right now. So hopefully in the future I will have that cost for you. Tran, that's a great question. Two questions. How does COA measure care coordination quality? Are specific measures used? And yeah, so that's something we're actually working through now is how to evaluate. I feel like when you look at other plans too, that's a problem everyone's trying to solve is did our care coordination, was it that thing that made the difference in decreasing hospitalizations or ED use? So we are doing some evaluation and looking at like, if a member had a touch with us or engage with us for a certain amount of time, what did their usage look like before and after? Were we able to get them better connected to providers in the community? So we are definitely looking at that. We have specific measures in our contract that we're required to engage with a certain percent of members. They do want us to reduce hospital readmissions and ED visits, and they're looking at setting a baseline for us based off of baseline data that we're still getting from the state, but we will be measuring those things. Let's see here. For hospitalization and EDs, does COA take care of those members or do we delegate? So if they are connected to a care coordination partner, that care coordination partner will do the transitions of care. If they are not part of a care coordination partner and are one of those highest risk members, we will do the transitions of care. What else? I know I'm right at time, but if anyone has a quick question,
Fast and Furious.
I
I have a
know.
quick follow-up to my second
Yes.
question.
Yeah.
So I know that you said you got the daily like the registry from hospitals and ED. So do all of those, even if it is a CCP that you sent you, does all of that get filtered through the centralized system first, and then you let the CCP know that they have a member who was hospitalized?
Yeah, so they get their own separate daily list. So each clinic
Okay.
will be sent like their clinic's list. Like, here's your people who went to the hospital and they do their thing. And then on our internal team, those members are already filtered out and we can go straight for those tier 3 members.
Thank you. That's helpful. And for the
Yeah.
quality piece, I know there's things in the contracts that are required, but also knowing that what you have for your excellent, like what is excellent care coordination, like that, I think is what we're interested in learning too. Like, how do you all do that? That's maybe a little bit more qualitative and not so black and white as far as metrics. So happy to hear you're working on that and we'll love to know
Yeah.
more in the
And we're looking more like surveys too. We do a net promoter score for NCQA, which we're pursuing right now at Colorado Access. We do have for a complex case management program, a very specific survey, asking some things that NCQA requires that we might, depending on how that survey goes, branch out more to all of our programs to also get that member experience aspect. So not just focusing on those clinical outcomes, things like that, but also that member experience piece of it.
I didn't know they have this CCP care coordination partners list, of which Stride and Salute and the major primary care organizations are part of. So really, it seems like when someone at Stride or Salute or Doctors Care uh, needs to refer a patient for something beyond what primary care can handle, it's really up to them, those organizations, to do it, and they should be equipped to be able to do it. But what I would like to know more about and explore is how much time can the CCPs, the care coordination partners like Stride and Salute, or the care coordination services, which is Colorado Access, actually spend doing the care coordination, as opposed to, okay, it looks like for your primary care is recommending rather urgent visit to the gastro guy or the neurology guy. And so the patient tries and gets a 6-month wait. And what mechanism do they have, whether it's a Stride or a Salute or Colorado Access, to actually take on that patient and act as the advocate for that patient, at least to get that patient into the front door one way or another. That doesn't mean arguing with the specialist who says, there's a 6-month wait, but trying to find other specialists, but not telling the patient, well, you're stuck with a 6-month wait, or will they actually go to work to try to find another specialist? There are hundreds, not hundreds, dozens of specialists in different areas. And would to what extent are they staffed to do that? Because if they tell the patient, well, I researched it, and you personally, you don't know English, you don't know the systems, you don't know how to work with systems, can call XYZ and do your best. Or to what degree do they actually go to bat with them? Can they do that? Because that, I think, in our neighborhood at 80010 is a major issue, that they are not equipped. I know Jamie said they're working to empower their patients so that they can do this stuff on their own. And that's good for you and me and Bobby and Christina and Teresa and Lauren and Denise. But for most of the people that are out there in the tough world, uh, it's going to take a lot more hand holding. So that's what what I was curious about and exploring with Jamie, but the other questions were also important to explore.
It's a good question. I spoke with Allison Dreyer at Stride yesterday, just talking about this issue. She was unable to come to this meeting, so I can follow up. She had great things to say about coordinating with Colorado Access from the Stride perspective. So
Mhm.
I think that would be a good follow up. Following up with Jamie, she's in the loop now. She understands this group, so following
One
up with her about that.
one
Go
thing
ahead.
to maybe ask about is, because I think one potential barrier that might be there is that if a referral is placed to a specific provider or a specific group, then they can't override that. That's basically an order from a physician. So they couldn't override it to look elsewhere. And so, and I don't know what the practices are for, Stride or Salute or things like that for that. But I suspect they refer to specific places, not just because they have people they know and they trust.
Yeah. Is there such a thing as a primary care referral to neurology? Like any of them? Do you have to specifically? I'm curious about that.
Yeah,
No.
I mean, it depends on how the group is structured.
Hmm.
So, like at the university, you can send a referral to neurology, and then they'll figure out the most appropriate person for them to see.
Hmm.
But I don't know how, like if they're trying to use, if they have I do know some of our private practice specialties do have relationships um, with referring organizations like that.
Hmm.
So they're not as common and not as well known, but
And for the sake of, no other practice group is here right now. So we're obviously all referring into CU. But if somebody, if there was less availability there, but another health system there, it was easier to get into or quicker. I'm just curious if they would have to do the referral into
it,
every single.
yeah.
That's hard. Okay.
Well, Christina, within the UC system there, um, so they're working within the a patient's working there, and the work is being seen within there and they're referred to a UC specialist in whatever area, neurology. And and the primary care is saying, you know what, you'd better see that urologist as soon as possible. This, looks kind of serious. I don't say it is, but you really need to get some tests done. And so they get an appointment, but it's 2 months down the road. Is there a route that's maybe not promoted too much because it's tedious to get that patient into within UC system in an urgent way to see a specialist, if that's what the
Well,
primary care
that was
doc.
some of the things that she was talking about. But one is they have advanced practice providers, mostly nurse practitioners, but some physician's assistants also who do screening. If they get a referral that's truly urgent, like it's going to cause life or limb issues within that period of time,
Okay,
then they will address that. But if they call in and get an appointment in 2 months, then they've pretty much beat the system. That's shorter than the average for neurology
yes,
for anyone.
yes,
Yeah, it's. I mean, we have such a overall healthcare system catastrophe coming around specialty access, I think.
yeah, it's always been a catastrophe. Now we're looking at a double catastrophe coming, I know. Yeah, so if the patient is persistent and savvy enough, you can do some specialist uh, research and take some time to do it. And very often they can get something, an appointment that is more timely.
Yeah,
They do
they
that.
can do that.
They can do that, but many folks just don't have that ability to do
Sure, exactly.
that. Okay, but it's good to know there is if the primary care says, this is not something we can wait 2 months for, this is really, I would call urgent, then there are means to get that patient into a quicker visit if it truly is emergent or
Yeah,
urgent.
yeah,
All right.
Yeah.
Thanks, everyone.
All good questions. Thanks for your
Thank you.
organizing.
yeah.
See
Thank
ya.
you.
Thank you.
Mandy,
Have a
Bobby.
good summer.
I